Hi, everyone. My name is Lynn Hernandez, and I'm with the Desmoid Tumor Research Foundation, or DTRF. Thank you so much for joining us today as we're still celebrating Desmoid Tumor Awareness Month. We're going to get started shortly, so get comfortable for our time together. You're invited to make comments below. In the interest of time, we'll be holding off on questions until the end. Okay. Welcome to our final live event in honor of Desmoid Tumor Awareness Month entitled, What's in a Name? Cancer and Desmoid Tumors. We're honored to have with us Dr. Raphael Pollock, Director of the James, the Ohio State University Comprehensive Cancer Center. Cancer and desmoid tumors is a topic that's frequently discussed within the desmoid tumor patient and care partner community. We want to start by saying that there is no right or wrong answer when it comes to an individual patient's feelings about their personal experience with this disease. We ask that you please keep this in mind throughout the broadcast. Today, we're going to cover some key definitions and hear more about why desmoids are categorized the way they are and the upsides and downsides to this categorization. It's important to note that Dr. Pollock will be sharing his personal and professional opinions with us today, and they may or may not reflect those of DTRF. Please note, none of what we discuss today should be taken as medical advice. Always talk with your own physicians when making decisions about your care. At last, finally, I'm honored to introduce you to our distinguished guest speaker this afternoon, Dr. Raphael Pollock. Dr. Pollock's medical career spans roughly 40 years. His clinical and laboratory research focuses on soft tissue sarcoma, including desmoid tumors. Before we get started, once again, we'd like to invite the community to post below. In the interest of time, we're holding off on questions until the end. Dr. Pollock.
Hi, Lynn, and thank you for including me in this speaker series. It's a tremendous honor and privilege, frankly, to have the opportunity to share some thoughts about desmoid tumor with the audience. That includes many desmoid patients, some of whom have contacted me over the last 24 to 48 hours. And part of my perspective is not only as a desmoid tumor care provider, but as a cancer patient myself. I have chronic lymphocytic leukemia. I am coming up to my 5-year survival point as of January of 2022. I have been in 2 clinical trials. I can talk with my own patients and others about cancer fatigue because it's something that I experience on a daily basis. And in a paradoxical way, the fact that I'm both a cancer care provider, but also a cancer patient has brought me that much closer to my patients. And I'm very grateful that that is the case. So thank you again for including me in this really outstanding Desmoid Tumor Awareness Month set of seminars.
Thank you so much, Dr. Pollock. And we really, really appreciate the fact that you're able to bring your experience not only as a cancer patient, but as a clinician to your work with desmoid tumor patients. There's so much value there. And we appreciate that transparency. The whole community wishes you well, of course.
Thank you.
Okay, so let's get started. This is a complex topic. We're going to be talking about cancer and desmoid tumors. So let's start with some definitions to get everybody on the same page. Dr. Pollock, tell us, what is the textbook definition of cancer? How nebulous is this term? How specific?
Well, there's a couple of sort of cardinal manifestations of cancer, and 2 properties that are very specifically important in that regard. One is the ability of a tumor or an abnormality to recur after definitive treatment and potentially pose local invasive problems, and that certainly describes desmoid. But the other hallmark is the ability of cells to detach from that primary tumor and spread and successfully lodge elsewhere in the body, and that's called metastasis. Unfortunately, desmoid tumors do not have the ability to metastasize, and it's generally maintained that they do not have the ability to degenerate into some other type of cancer that can spread elsewhere in the body. There is a situation called multifocal desmoid where patients will spontaneously develop desmoid tumors in more than one location, but that's a very rare situation, and it's not a true spread of desmoid tumors from the original primary. Then I can't hear you. Something has happened to your audio.
Oh, sorry, I
Oh,
didn't
there you
turn it
go.
back on again.
Yeah.
So yeah, that we really appreciate your breaking that out for us. Patients are often told upon diagnosis that desmoid tumors are benign. Can you tell us what that means?
Well, the unusual feature of desmoid tumors is, that I mentioned, that they can recur and they certainly can invade locally, but they don't have the ability to spread. Patients will ask me, is my desmoid a cancer or is it benign, meaning that it behaves in a much more biologically innocuous fashion? And my answer to the patients are, and this sounds like a little bit of fudge, but let me explain. It really depends on the context in which the patient is asking the question. By that I mean, let's say hypothetically that a patient wants to know that answer because they're going to be applying for some additional insurance coverage. In that case, we would make it very clear that we consider this to be a benign situation because it doesn't have the ability to spread elsewhere in the body. On the other hand, we are sometimes referred patients with desmoid from physicians who may not be that knowledgeable about the desmoid problem and be somewhat dismissive, saying, we don't want to bother your schedule. We have this patient with this benign problem. And in that context, we make it very, very clear that we consider this to be a serious and at times even life-threatening illness, and in that way analogous to a cancer. So when the patient asks me, is this benign or malignant, my response is first to try to learn a little bit more about why they need to know and what they would do with that information, so that I can make certain that they get the appropriate answer that's tailor-made to their individual situation.
So I appreciate your answer. I didn't hear the last part, but I'm sure you nailed down benign. That's interesting. We hear that a lot of patients, when they hear that their physicians say that this disease is benign, that it's invalidating to some patients, right?
Yeah.
I know that in regular life, when we say something is benign, it's really not that big of a deal, but that's not necessarily what physicians may mean. The medical definition is
No,
different.
that's absolutely correct, Lynn. Benign problems don't cause intractable pain. They don't cause loss of quality of life with inability to fully extend extremities or engage in other important physical activities. So to call it benign, I think, is something of a misnomer. But again, it really depends on the context. I would not want to have a patient inappropriately treated by a physician who simply may not know that desmoids, although they can't spread elsewhere, are hardly benign in how they behave or their potential impact on a patient's quality of life.
I'm hearing that. I'm hearing that. The World Health Organization and the American Cancer Society have categorized desmoid tumors as intermediate soft tissue tumors. Can you tell us a little bit about the term intermediate in the context of tumors generally, and what makes desmoid tumors intermediate?
Yeah, again, it goes back to the hallmarks of what constitutes a cancer versus what is not a cancer. And those two hallmarks are the ability to recur locally and invade, as well as the ability to spread elsewhere in the body. The desmoids certainly can do the former, but they don't have the ability to spread elsewhere in the body. So on a spectrum of aggressive biologic behaviors, the desmoids fall somewhere in the middle, which is why the term intermediate is used in describing desmoids. I'm not sure that that's necessarily the best term, but it certainly is a term that we can use as a convenient form of expressing what the biologic behavior is of most desmoid tumors. And it's a reality that although there are many patients who die from their desmoid, the majority of patients will will survive, as compared to the majority of patients who actually have tumors that can and do spread elsewhere in the body, the process called metastasis, where because the spread is driven by genetic abnormalities in some cells that come from the primary tumor, it has a more ominous meaning to a patient in terms of being able to survive their tumor experience.
What characteristics of desmoid tumors make them not fit perfectly into the typical cancer category? Why is it so hard to say, yes, it's cancer, or no, it's not cancer?
Well, when we talk about cancer, we're actually referring to an aggregate of somewhere between 400 and 500 specific diseases that have a number of properties. And in order to be, if you will, a full-fledged aggressive cancer, it has to, by definition, be able to ultimately grow in an uncontrollable fashion and spread elsewhere in the body. And desmoids simply don't have that ability. So in my mind, one can make a clear definition of this, a visualization, if you will. And what it really comes down to is there's three categories of these types of abnormalities. We use the word benign, but they don't behave in what the Oxford Dictionary definition of the word benign means, and yet they don't have the ability to spread, but they can recur and they can invade locally. And anyone who underestimates that has never seen a desmoid that can and does erode through bone or any other structure that's in the way of its growing in the directions that it might want to grow. So in my mind, one can therefore see this as a spectrum that goes all the way from non-aggressive, if you will, or benign, to aggressive tumors. And then because it's a spectrum of biologic behaviors, there's a large gray zone in the middle, and that's where desmoids ultimately, as a group, fit in.
Okay, thank you. Okay, so now that we've gone through some of this terminology, can you share how you would describe desmoid tumors to a newly diagnosed patient, somebody that does not have a lot of experience with this terminology at all?
Right. I'm very grateful when patients come to see us for their care, or even just for a second opinion or a consultation, because it's a very rare abnormality. There are approximately 1,000 new desmoid diagnoses in the United States on an annual basis, and that compares and contrasts to 280,000 new diagnoses of lung cancer, for example. The reason that that is an important observation is that if you think about it, very few medical practitioners have much experience with desmoid. And because the therapy for this disease is very complicated and involves multiple different potential approaches, working with desmoid expert physicians is extremely important. And I think that that message has been communicated by the DTRF very effectively, especially through the Desmoidian website, where patients are very aware of the need to access expertise.
I'd like to remind the community to please post any comments or questions that you have in the chat. Again, we'll be taking questions at the end of the broadcast. So Dr. Pollock, I know that you just answered that question about how you would address newly diagnosed patients. You've said that before that when desmoid tumors are not treated as cancer, they can be deadly. Can you expound on this philosophy?
People who don't have experience, physicians who don't have experience treating patients with desmoid, will frequently underestimate the potential for the desmoid tumor to do impact by invading other structures. What appears to be a small mass in an easily accessible location, say on the abdominal wall, may indeed burrow right through the abdominal muscles and invade the liver or the intestinal system or the bladder. And being unaware of those biologic possibilities means that a practitioner is not going to be prepared for that potential and therefore may not understand the importance of how to treat the desmoid appropriately. So we want physicians who are going to be involved in caring for desmoid patients to become aware of the serious potential biological impact that these tumors can have. If you're prepared for that possibility and you never get to that point, then the patient is that much further ahead of the game.
Okay, thank you. Thank you. And I'm hearing that, so much depends on education for physicians, right? I mean, that's
Yes.
just a huge piece, a huge component. Okay, as you know firsthand, desmoid patients are treated by oncologists and sarcoma specialists. Many undergo chemotherapy treatments and radiation. Depending on the treatment, some even lose their hair. Because of this, there are members of the community who find the word cancer fits their experience and helps other people understand the weight of what they're going through. The word can be validating. Others feel their experience is quite different, and the term may feel misleading. As we know, the desmoid experience can vary widely. What would you tell patients trying to navigate communicating about this rare disease to others in their lives?
Well, I think that it's very important, particularly for the people who are part of the patient's support system and family, that they understand that this is a problem that has serious potential and that the patient needs to be followed very carefully, seek out appropriate medical care that is in the hands of desmoid knowledgeable practitioners, that it shouldn't be dismissed as a trivial problem, because although it may ultimately not prove to be a serious life-threatening condition, the desmoid can behave as something that can really be a challenge to an individual patient. And it's very important for the patient to know that they can not only trust the information and the quality of care that their practitioner is providing to them, but that they have what I would term trustworthy support from the people around them who are truly important and caring about their overall health and how their problem is going to be handled.
Thank you for that. And I know you and I talked a little bit before the broadcast where we were talking about your current cancer diagnosis and status. And you said something very poignant, actually, about a week ago when we spoke, something to the effect of, and I don't want to quote you, but you kind of compared your situation to a desmoid tumor and said that said something about I don't remember exactly what it was, but you I'm going to throw the mic over to you. I think you know what I'm
Sure.
talking about.
Yeah. Well, both chronic leukemias and desmoids tend to be relatively slow progressing compared to other types of cancers where the potential for more rapid uh, oncology behaviors exists. The ability to spread and spread early in the context of the disease. Desmoid tends to progress more slowly if it actually progresses at all. And that's also in some ways the case with chronic leukemias. If left to their own timetable, they will progress. But there are some very effective therapies that can be used to control the disease. I'm fortunate to be able to take such a drug, a form of chemotherapy. I will be on it the rest of my life. I have what's called stage 3 disease, meaning that I have fairly large leukemia deposits on both sides of my diaphragm, which is the muscle that separates the chest from the abdomen. And those deposits are around the aorta, which is of the large blood vessel that brings blood from the heart out to the rest of the body. They are slowly shrinking, which is good, but they are very much present and enlarged. They don't really cause me much in the way of symptoms directly, but the cancer fatigue that I do experience is probably attributable to the still active disease. So, in an analogy to desmoid, it's a tumor situation that I think one can learn to accommodate to live with, to be in balance with. The potential for things to change, potentially in a deleterious way, is always there. About 10% of the chronic lymphocytic leukemia patients will develop a disease called Richter's transformation, where it becomes a very aggressive lymphoma for which we don't have effective therapies, and the life expectancy after that transformation takes place is about 3 to 6 months. So I live with that reality, but how do you handle it? And in this way, I think it's also analogous to desmoid patients who live with the reality that they have a problem. The problem can cause serious life-threatening consequences and certainly damage the quality of life. So how do you live with that? And I think it's a fork in the road. You can choose to back away and involute and let the disease have a very profound impact, or you can say, okay, I get it. This is my problem. I'm going to go ahead, though, and do the things that I want to do with my life. My tagline that I tell the patients and try to live myself is, don't let your disease take any more of your life than it already has.
I'm hearing that, Dr. Pollock. Unfortunately, we've heard from patients throughout the years that people in their lives, even some of their physicians, have told them things like, and I'm sure you've heard this before, it's not a real cancer, or at least it's the good type of cancer, or if it won't kill you, then it's not cancer. Some even receive less support from loved ones who don't understand the nuances of this disease since they may not look sick. As one of the few physicians who have seen hundreds of desmoid tumor patients and studied this disease so thoroughly, what advice would you give to patients who receive these types of comments?
I think it's important to process what you're hearing and think about why someone might tell you that. Uh, Unfortunately, physicians who may not be knowledgeable about one or another disease may tend to, in some ways, belittle its potential impact or importance, whereas a arguably more appropriate response would be, gee, I don't know much about that disease. Let me get you to someone who does know that. Patients and their family members, it's possible in some circumstances that the family members, for obvious reasons, would deny the unfortunate potential reality of a disease that can really damage the quality of life of a loved one. And at times, it may be a little bit of magical thinking to think and communicate this can't be really serious, or you should just get on with what you want to do because this is not going to kill you. And while thankfully in the majority of patients it generally won't kill you, but it can certainly damage the quality of life. And I think that anyone who doesn't believe that possibility should just spend a couple of minutes with the Desmoidians in the chat room to get a real education about what this disease can do to people and how it can really damage people's lives and deter them from being able to do things that are very important for them to be able to accomplish.
Yes, I really hear that. And I think that, a lot of people, a lot of our listeners and a lot of people watching, I'm sure, are connected with the Desmoidian and have provided support and even, gone there with their own support needs. And I think that it's truly, that community is truly a testament to the support that a community can give and how that type of support, whether it's emotional or this is what worked for me, right? It's very powerful. And I'm sure a lot of people's loved ones could learn from being in that room. The way that we think about and describe desmoid tumors can have a real world impact on the treatments that are used. It can also have a real impact on those who are living with it, and experiences can definitely vary. Another impact it has, which is very real to our patients, is financial impact. If a patient is struggling to make sure a public or private entity understands their condition, I know this is a shot in the dark, but do you know or can you speak to anything that their medical team might be able to do to help?
Well, probably the most important way that a desmoid caring team, and I like the use of the word team because that's going to segue into my answer to your question directly. We talk about financial toxicities, and that sounds in some ways almost like a little bit of a euphemism, but it's very, very real. And when you put together the costs of planning conferences, the costs of potentially very challenging surgical operations, frequently with extensive reconstructive surgery, the costs of systemic therapies, because after all, whether one ultimately considers desmoid to be a cancer or not, cancer chemotherapy is a standard component of desmoid treatment. And those therapies have their own side effects, which in turn may need to be treated. And then the cost of radiation. So if you put all of those factors together and aggregate the costs, the bill can run up very, very quickly, as is the case, analogously, with many cancer patients who experience multidisciplinary costs. So not to be belittled, and that's something that practitioners can really help a patient with by trying to address third-party payers, providing education as to the true costs of being a desmoid patient. And that type of information is frequently retrievable at centers that have experience in multidisciplinary connective tissue tumor care.
And I think we've lost Lynn for a second there.
Okay.
Again, I'm sure she'll be right back. In the meantime, while we're getting her back, Dr. Pollock, I was wondering if you might want to answer just a couple of questions we've received thus far.
Yep.
So somebody was just curious a little bit about some of these definitions that we were talking about earlier, asking, does malignant mean cancerous? Could you maybe answer that for us?
And the answer is yes. Malignant is synonymous with cancer, but it's a very broad descriptor of a biologic process that has implications about the ability to recur, to invade locally, and to spread elsewhere.
Mm-hmm. Okay, and hopefully that's helpful to that person who asked that question. We also got, is it appropriate to call desmoids a non-metastasizing soft tissue sarcoma? Does that sound like a good terminology?
That's a very good question, and frankly, that's how many of us think of the disease because of the ability to recur in the local area, and I think that it actually speaks to the biological reality of how the desmoid behaves. So that to me would be a very appropriate definition. Again, it depends on the purpose. I would not use that description necessarily if I was approached by a third-party payer who wanted to know if this was a cancer patient who therefore would be not insurable as such. I would choose my words very, very differently.
Okay. Great, and I think Lynn is back with us, so I'm going to turn it back over to her, and we'll move on to some more questions. Thank you.
Okay, thank you so much, Amanda. We really appreciate your support. Okay, so our next question up is, I've heard it's basically an overgrowth of scar tissue. Is that true?
No. It can be associated with scar tissue formation, but it's not an overgrowth of scar tissue per se. It's a different biological process, and we can differentiate it on a molecular level. There is a protein that is very commonly overproduced in desmoid. It's called beta-catenin, and that protein is involved in cell-to-cell communication. And desmoids, a hallmark of desmoid is that beta-catenin protein is significantly overproduced in comparison to normal tissues or scar tissue. So one can differentiate those two on a molecular level, and they are different. In a similar manner, people will sometimes say, well, everything was fine until I was in this auto accident, and then I started feeling this mass, say, behind my knee and my leg. And typically what that really means is not that trauma caused the mass to form, but that trauma in one or another body area focused the patient's attention on that area, and then they appreciated that there was something there. So animal models have tried to demonstrate without success that trauma or scarring can cause desmoid tumors. Now, having said that, putting aside the issue with beta-catenin, the biology of wound healing can sometimes incite or has similarities to what we do know, which isn't very much, about desmoid progression. So that's something to bear in mind. And one of the clues to that reality, a very common location of one type of desmoid is in the abdominal wall, and that is typically in women in the peripartum period, in other words, around the time of a birth, defined as up to 2 years after birth, where a desmoid will develop in the abdominal wall muscles, and that is thought actually to be due to an abnormality in the repair mechanism that those muscles undergo due to the stretching that they undergo as part of the pregnancy process. But that doesn't specifically tie the formation of scar to the ultimate evolution into desmoid. We don't see that transition. There's an association, but it's not a cause and effect transition.
Okay, thank you. Another question, another person watching asks, can a desmoid patient experience the same type of symptoms as a cancer patient? For example, being tired, night sweats, etc.
And the answer is yes, very directly. You have to think of of cancers, including desmoids, including leukemia, including sarcomas, including breast cancer. These are very energy-consuming processes, and in some ways, the tumor is in competition with the rest of the body for energy. And the other aspect of it, of course, which we don't understand very well, is that the tumor can release certain proteins into the circulation, which in and of themselves can cause the symptoms of fatigue. There are biological analogies between desmoid and other types of cancers, leading to some very comparable symptoms. And for that reason, if a patient develops those types of symptoms, like unexplained fatigue or a mass that can be palpated, they should call it to medical attention sooner rather than later to make sure that, to the extent that we can define it, that we know why the patient is experiencing those symptoms.
Wow, thank you. Thank you for that. I know that we're getting some more questions
Good.
in the comments. I just want to remind everyone to please feel free to post in the comments. We're still going to take a few more questions. So Dr. Pollock, our next question, are there specific markers for desmoid tumors?
Yes. As I mentioned, the beta-catenin protein is a very definite molecular marker, and the test for the presence of beta-catenin protein can be done even off of a small needle biopsy. It's a type of an analysis called immunohistochemistry, and that's very commonly available in departments of pathology that are called on to analyze pathologic tissue biopsy. It's a very common and very routine approach. So that's something where a patient knowledgeably, if someone came back and said, well, we've done this biopsy, we don't know if it's desmoid or something else, it would be important for the patient to say, well, have you looked at the beta-catenin levels? Because that can help rule in or rule out the diagnosis. Now, the story gets a little more complicated beyond that because, and this is something that our group, when we were all together down at MD Anderson, have spent a lot of time looking at. The genes, the DNA genes that control the production of beta-catenin actually come in only 4 different varieties. That's a little bit of an arbitrary statement. They tell us in medical school, never say never and never say always. But it appears that there's a very limited number of genetic mutations that drive this overproduction of beta-catenin. And while there is controversy in the literature about the importance of one or another of these gene mutations, and there's controversy because some are more common in extremity locations in desmoids. They're certainly more common in larger as compared to smaller desmoids. So their expression is a little bit of multifactorial control, where you have to look at both the location as well as the size and whether it's a primary or a recurrent desmoid. So the story is not complete and the jury is not out, but there may well be an association with one or another of these genetic mutations and subsequent desmoid behavior, particularly the issue of recurrence. I don't want to read more into it than it would be justified by the information. And this has certainly been an ongoing subject, not only of scientific debate, but DTRF funded research, not only our laboratory, but a number of other laboratories around the world who are looking at this and trying to define the role. And so we all appreciate that keeping an open mind about the underlying molecular biology will ultimately help us as an investigative community come to a better understanding. Having said that, we do know that the high levels of beta-catenin that are produced by desmoid tumors can differentiate them from routine scar or from other types of solid masses, including other sarcomas.
Okay. Thank you for that. So let's see what else we have. So some tumors go away with treatment. How often does this, without treatment?
Yeah.
How often does this happen?
We don't have a totally accurate handle on that question, which obviously is very, very critical. This is the subject of a watchful waiting clinical trial that has been conducted by our desmoid colleagues in Europe, where it may be that as much as 25 or 30% of these tumors will spontaneously either stabilize or decrease in size without additional treatments. And that becomes very important, particularly if the tumor and the surgical management of that tumor would be very tissue destructive in a way that could compromise someone's quality of life. Now, the catch here is that watchful waiting as a therapeutic option, and I tell patients this is not doing nothing, because the patients get very regular scanning to follow the tumor. I tell them it's like putting a very effective guard dog in front of the chicken coop. You aren't doing nothing, but it's unlikely that the foxes will get in with that good guard dog, which in this case is the radiologic scans, keeping tabs on things. But that approach has to be performed by people who are knowledgeable about desmoid biology and behaviors. Because if the tumor starts to progress on watchful waiting, then that really mandates that the desmoid team that's helping to manage that specific patient's issue reconvene and reconsider all the information and decide, is further watchful waiting mandated, perhaps given the rate of growth if it's growing or the anatomic location? Or at that point, do we really need to move into a more aggressive therapeutic approach to handle that individual patient's problem? Which is part of why being taken care of by a team of desmoid experts really becomes a very optimal situation for patients, particularly if they were going to be in a watchful waiting program.
Okay, thank you. Dr. Pollock, we are so grateful that you have taken the time to meet with us today. And I apologize again for all the technical issues. And thank you so much to Amanda, who has been behind the scenes troubleshooting everything. So yes, we thank you. Do you have any final words that you would like to share with the community?
Well, I would say that the cup is certainly more than half full. Uh, I'm a member of a number of different uh, soft tissue tumor research and patient advocacy groups. And one thing that I've just been very, very consistently impressed with is the quality of the interaction that the Desmoidians provide through the website. This is clearly the most active patient support group that I'm aware of. And one of the things that I think is really effective about it is, they don't pull any punches. And so the information that's provided and the support that's provided is the real deal. All the way down to, gee, just came out of seeing Pollock. He's having a bad hair day. Whoever's going to see him this afternoon, beware. I really appreciate that level of candor. And I think that it's really been instrumental in not only helping patients seek out the care that they need, but it's also been a wonderful entree point for patients to know about the DTRF and the patient educational materials that are on the DTRF website. These have been developed by Desmoid experts that, upon their completion, are then reviewed by other Desmoid experts, revised periodically. In other words, it's information that the patients and their families can truly count on. And that's very, very important when you have a rare disease where it's not clear, we don't have all the answers. So being able to get authoritative information to the extent that it's available, and being able to seek out and know that you're going to get supported by other people with the disease is just very, very critical. And for that, I am totally grateful to the DTRF, with which our group has been associated for so many years on a volunteer basis. So thank you for being able to have me participate in this seminar series. And certainly, if there are other questions that come up at any point, I can be approached through the Desmoidians or the DTRF, and I would always be happy to respond and try to help any patient with whom what I know might be of use. So very, very appreciated all the way around.
Thank you so much, Dr. Pollock. Lynn, we've lost her once again, but maybe she might jump in just before the end to think about everyone. But I just wanted to thank you so much for your time, for explaining all of this extremely complicated stuff very clearly. I know there are many people in the comments who are thanking you for how you've laid everything out. So truly, we appreciate it. I just wanted to let everyone watching know that the DTRF Together We Will virtual weekend events, specifically the patient meeting webinars, were recorded, and those recordings will be available within the coming weeks. We just got to work on some of the captions and transcripts and things like that, but they will be coming, and a lot of questions that I've seen in the comments can be answered by some of the presentations that were given during that amazing weekend. So I think we do have Lynn. I'm going to let her wrap it up. And
Great.
Thank you.
And thank you, Amanda.
This has just been a whirlwind.
But hey, you did it.
That's what we do, right? We just make things happen.
Yeah.
So I have a couple of announcements for the community before we go. First of all, thank you to Dr. Pollock. Thank you to the community for being with us this afternoon. If for whatever reason you started listening in the middle of the broadcast, we urge you to go back to Facebook. This will be stored under our live videos. It will also be on the Desmoid Tumor Awareness Month page on our website at dtrf.org/awareness. So you can find the video on Facebook or on our website. And I also want to just reiterate that we just finished our Together We Will virtual weekend, which was fantastic. We had 2 patient meeting webinars that we recorded, and there's a lot of great information on there that we will be sharing. So that's it. And just thank you again to Dr. Pollock. And I'm going to let him wave and say goodbye to everybody.
Thank you, everyone.
Bye, everybody.
Yeah, bye-bye now.
Bye. Take good care, everybody.